Good evening. This is one of the great occasions of the year when we ask some of our most distinguished faculty to come and to talk about things that they've been working on. And today, that's what we will hear from one of the most remarkable people, I think, at Columbia University, Wafaa El-Sadr. And Linda Fried will come up after I'm done and make some introductory remarks and then moderate questions and answers. I just want to say a few things. I feel like I was there at part of the beginning when Wafaa took on this project of working on HIV/AIDS, because I was traveling in Mozambique and went to the place where you had new people who were sort of beginning to set up the operation there. And so I had a feel of the excitement and the importance of this. And then, of course, over several years, this was staggeringly effective. And I was just saying to Wafaa, in my field of law, nobody ever speaks about scaling up. It's just not a concept that we use in the law. But out in the field where you do things, and not just rule about things, there the big question is always, how can you bring this to scale? How can you scale up? And I think this person right here is one of those, maybe with the Marshall Plan, if Marshall were here, who could say, we have scaled up something of incredible importance that has affected the lives of millions of people. And that in itself is just an enormous accomplishment. And if we can learn anything tonight, I mean, I know we'll learn many things, and we'll have the treat of hearing the life story of someone of great accomplishment. But if we can learn anything, we will learn about that phenomena, which is incredibly important. The other thing that's really impressive to me about Wafaa is that she is Egyptian, but wears cowboy boots. And several people, I've seen several people remark on this. Bill Clinton, actually, when he was here with Wafaa a few years ago, made exactly that comment. An Egyptian with cowboy boots. I mean, where did that happen? For a lot of years, I wore cowboy boots because I grew up in cowboy country. Wafaa didn't grow up in cowboy country. So there's a kind of story there that I hope we'll get some insight into. Wafaa, thank you so much for doing this lecture, and more importantly, for all that you've done for so many people in the world, and in your research, in your scholarship, in your teaching, but also in this great service you've performed. Wafaa. Linda Fried.
Good afternoon, everybody, and welcome. It's my great honor to stand up here, both on behalf of the Mailman School of Public Health, but particularly on behalf of Provost Coatsworth, who will be here momentarily, got delayed on the way from the airport, to introduce our speaker today. Dr. El-Sadr is a truly revered member of the Columbia University community for almost a quarter of a century. And she is well known to many of us as one of the world's leading experts in the care and treatment of people with HIV and tuberculosis. She was born in Egypt, received her medical training at Cairo University without cowboy boots, and holds degrees from the Kennedy School of Government at Harvard University and Columbia's Mailman School of Public Health. Dr. El-Sadr arrived at Harlem Hospital in 1988, where she created the hospital's first and enduring HIV/AIDS and tuberculosis program, and for more than 20 years was the chief of the Division of Infectious Diseases. She's a professor now at the Mailman School of Public Health, as well as the College of Physicians and Surgeons at Columbia University, and is the founder and director of ICAP, known by medical professionals the world over as a major global leadership center supporting large-scale programs in public health and healthcare provision. Along with Alan Rosenfield, my predecessor as the Dean of the Mailman School, Dr. El-Sadr established the Mother-to-Child Transmission Plus initiative, a program that has had a really transformative public health effect in more than a dozen sub-Saharan nations bearing the brunt of the HIV/AIDS epidemic. In 2008, Dr. El-Sadr was honored by being named a MacArthur Foundation Genius Fellow. That was capped off in 2009, quite appropriately, by being named by Rolling Stone as among the top 100 agents of change, and simultaneously by Scientific American, who picked her for the first annual honor roll of the top 10 people leading innovations that benefit humanity. In 2010, she was elected to the Institute of Medicine of the National Academy of Sciences. It is tempting and completely natural to describe the magnitude of Dr. El-Sadr's impact by referencing the numbers of lives touched by programs of her creation and under her direction. In Africa, Central Asia, and the United States, ICAP has helped more than 1 million people living with HIV gain access to HIV services that work. And those programs have assisted, in addition, more than 500,000 individuals in receiving access to life-saving antiretroviral therapy. It is an astounding record of accomplishment and public service, and one that is humbling to all of us to consider. And yet, for many Columbia students and colleagues who have learned from Dr. El-Sadr over the years, her example stands for something else, which I think is also awe-inspiring and touches our lives quite directly. Simply put, Wafaa has demonstrated what it means to live a life fully dedicated to research, teaching, and serving humanity. Her career epitomizes Columbia's mission and the mission of all great research universities. To achieve this, Dr. El-Sadr has traveled her own personal journey defined by both courage and compassion, as well as excellence. In the summer of 1982, working as a young infectious disease physician at New York City's VA Medical Center, Dr. El-Sadr witnessed firsthand the onslaught of deathly ill gay men, most of them young, and ones who had recently been healthy. And they were coming to the hospital with a confounding new disease that displayed pathologies no one had ever seen before. For her, and for others entrusted with protecting the public's health, it was an overwhelming and terrifying experience. But she was not deterred. The urgency of the need, according to her, eliminated any sense of fear. In a recent interview, reflecting on that time when she found herself in the eye of that storm, Dr. El-Sadr said simply, quote, "This opened my eyes to humanity like never before," unquote. This early experience led Dr. El-Sadr to adopt a set of principles to guide her work that are holistic and interdisciplinary. Hers is an endlessly embracing approach that insists on doing all that is necessary to secure the health of people on a large scale through a determined response to HIV and tuberculosis and an understanding of the common experience of patients in Harlem and patients around the globe, and a community-based model to combat this global epidemic. She works in medical care, she designs health systems, and she brings prevention effectively to communities. This is a truly remarkable legacy from which I and many have learned, and it is a legacy that has been responsible for healing and protecting millions from the ravages of disease. All of us at the university benefit from Dr. El-Sadr's presence among us and her unique leadership skills and vision. On behalf of President Bollinger and Provost Coatsworth, who is now here, welcome, she chairs the university-wide task force on global health. Dr. El-Sadr represents Columbia on the Consortium of Universities for Global Health, and at the Mailman School, she serves as the director of the Mailman School's Global Health Initiative. In all realms, she is a truly dedicated and inspiring leader, committed at every turn to doing more than her part to ensure that the unique contributions of a great university are brought to the world. Please welcome the presenter of tonight's university lecture, Columbia's Dr. Wafaa El-Sadr.
Thank you. Thank you very much. Thank you very much. Thank you, President Bollinger. Thank you, Dean Fried, and welcome, Provost Coatsworth. Thank you for the invitation for me to speak tonight, and thank you for the warm welcome and very generous introduction. I'm deeply honored to be here with so many of my dear colleagues and dear friends. In thinking about tonight's lecture, I had occasion to read the talk given by President Seth Low, the man responsible for building of this magnificent space, upon his installation as president of Columbia College in February of 1890. President Low spoke of what Columbia could learn from New York City, and in turn, Columbia's responsibility to the city. He urged the assembled students and professors to engage with the city, gaining inspiration, but also, most importantly, giving back in return. He said, "There's no such thing as the world of letters apart from the world of man. And the scholar without this vision is a pedant. He mistakes learning for an end of itself instead of seeing that it is only a weapon in a wise man's hands." These words, articulated so long ago, capture the essence of what I will be talking about tonight. So let me begin the story. I was a very young, much younger, infectious disease physician here in the US for postgraduate training in 1981, when my mentor in the lab where I worked in Cleveland, Ohio, came to the bench where I was working and placed right next to me this copy of the Morbidity and Mortality Weekly Report, the MMWR, of June 5th, 1981. In that edition of the MMWR, there was the first report of 5 cases of an unknown disease, of a mysterious illness. 5 gay men, young gay men, who came down with what's called pneumocystis pneumonia, a very rare, exotic kind of illness that is almost never seen in young people. These 5 men, unfortunately, also had many, many other complications as well, indicating that somehow their immune system was substantially weakened, making them very vulnerable to various infections. Now, I thought at that time that with our knowledge of epidemiology, our knowledge of infectious disease, that we'd figure this out pretty quickly, that this outbreak would be figured out, we'll know what caused this mysterious illness, and that'd be the end of the story. But this did not stop. Several reports came after that, including several other cases of mysterious illnesses, all in young gay men. One of them was a severely disfiguring type of cancer seen in this photograph. Now, where were these cases happening? They were happening largely in cities like New York, in Miami, in San Francisco, in Los Angeles. But there were few cases at the beginning. And again, we thought that this would go away. This was a mysterious illness that we would figure out quickly. But rapidly, very rapidly, the numbers of cases escalated. And in just a few years, there were already 100,000 cases of this mysterious illness that we now call AIDS, acquired immunodeficiency syndrome, just in this country. Now, there were hotspots of where this illness was particularly severe. And by that time, I had returned to New York, which was now at the epicenter of this epidemic. Shown here, the darker red areas in the map of New York City are the most severely affected areas, including the Harlem community. And just by chance, that is when I went to Harlem Hospital, my first appointment at Columbia University. At that time, this was at the very beginning of a crisis, and the hospital was in crisis. There were hundreds, if not thousands, of young people coming into the hospital, suffering with AIDS. It was babies, it was children, it was adults. We didn't know what to do. We couldn't cope with the load of the patients. Yet we had to overcome the fear and try to think of how to develop systems. How do we care for these families? How do we confront this epidemic? And what was very helpful at that time is for us to think about what were the characteristics of HIV and to shape programs that responded to the characteristics of this infection that was caused by this virus. So what were the characteristics of HIV? We knew it impacted through the life cycle. It affected babies, children, adults, even the elderly. It was characterized by periods of illness and periods of wellness. It had multiple clinical and psychosocial manifestations. It required lifelong care. It was a chronic disease. It needed secure supplies of medications and laboratory tests. It needed strong health systems. And most importantly, it was associated with severe stigma and discrimination. So it was these characteristics that led us at that point in time to shape the very first programs we had here to respond to this epidemic. So first we focused on how do we deal with this disease that was a family disease. So we decided to shape it based on the family approach, a family-focused approach. Thinking that for every man or woman that we saw with this disease, behind them there was a partner or there was a child who may be affected. And we thought that we needed to shape our programs to be family-focused, family-centered, to be able to give our patients what they needed. But then we realized that not only, as this headline in one of the newspapers, New York newspaper indicates that Harlem Hospital's lonely battle with AIDS, that these same patients had indeed a very lonely battle themselves with AIDS. They often did not have any families, or they had very, very weak social infrastructure and social support. This meant that we had to broaden our definitions of a family focus, and we established the concept of a surrogate family focus. And who were the surrogate family for our patients? The surrogates became the healthcare workers themselves. They created the family approach. They created the environment where the patients wanted to come. We became family for many of our patients. The other approach, and what we felt we had to do, was we had to deal with the multiplicity of conditions and challenges that our patients faced. And for that, we needed to establish a mosaic of services, a mosaic that included attention to mental health, attention to taking the medications on time, attention to outreach, attention to social support. And we also had to take people living with HIV themselves, peers, and train them to become advocates for their own other patients within their community. And as you can see here from some of these photographs, and on the central theme of the medications that many of the patients had to take, there needed to be a mosaic of other services, particularly peer support, outreach in the community, and psychosocial support. But we knew also that as we were building these programs, there was a missing piece of the mosaic. And the missing piece of the mosaic was research. We felt that there were many questions that our patients brought up, many questions that we had that could not be answered. And we felt that it was an integral part of building a comprehensive program to include that very important component, research. There were many challenges in trying to do research and to talk about research in a community like Harlem. As many of you in this audience know, there's a strong legacy of the Tuskegee study of syphilis in this country. And this study, in which hundreds of black men were recruited and followed for many, many years and deprived of treatment, has left a remarkable legacy of mistrust of research and mistrust of the healthcare system. So we had to think of a way to overcome this mistrust. Fortunately, the NIH, National Institutes of Health, established a very innovative and courageous program called the Community Program for Clinical Research on AIDS. And that program focused on engaging and conducting and designing and centering all the research in the community so that the questions arise from the patients, they're involved in the design, their providers are involved in the implementation of these studies, and the results go back to help the same patients. And this program was quite successful, including at Harlem, in getting at answers that were very relevant to the patients we took care of. Out of this work emanated a lot of scholarly activities and much research and much advances in the way we approached taking care of our patients. However, there was really no treatment for HIV, even at that time. This generated a movement that's very unique in the history of medicine, the advocacy movement for the HIV epidemic. And the advocacy movement for HIV that was really led by people affected and infected with HIV centered on two principles. You can see them here in this poster. Ignorance equals fear, and silence equals death. Lay people who themselves were infected or affected decided that they had to learn enough. They had to learn almost as much as the scientists knew in order to be able to push the agenda, in order to be able to push for finding treatments for this disease. Not only did they learn, but they also had to speak up. They had to go out and advocate. They had to go out there and demand that treatments be found and to try to accelerate the process of discovery to find answers to the HIV epidemic. This movement led to a complete change, a transformation in the relationships between people affected by any health condition and the providers and the whole health system. At the same time, HIV was beginning to rise in the public. Mainstream magazines like Time magazine, as you can see in this slide, had titles like "The Search for a Cure Stalls." Courageous people like Magic Johnson disclosed that he had HIV infection soon after he found out that he was HIV infected. And then Surgeon General C. Everett Koop sent to every household in America this booklet that some of you of a certain age in this room will remember receiving. Finally, HIV was being spoken of in the public domain. But yet, we had no treatment for many of these patients, and thousands of people were dying every day, including many of my own patients. The world changed suddenly and abruptly. At the International AIDS Conference in 1996 in Vancouver, amazing results of studies were disclosed. At that meeting, results that demonstrated that with certain new medications, HIV treatment medications, you could actually save people's lives. This was not the cure, but yet you can change the whole outcomes, the whole outlook for people with HIV. Indeed, it's interesting that the theme for that meeting was One World, One Hope. What happened next was very important and instructive. So here we had a scientific discovery of great value. But what we saw rather rapidly is that with expansion of HIV treatment in the US, as you can see here in the green curve, there was a remarkable drop in the numbers of deaths that occurred very abruptly, demonstrating that you can have fantastic findings, but unless you can take them to the people who need them and establish a scale-up, as President Bollinger was saying, you would not be able to see the impact at a societal level. At the same time, while we were tackling HIV in this country, the global pandemic was rapidly expanding. As you can see here, that the mid-2000s, it was estimated there were 30 million people living with HIV around the world. Now, where were these people with HIV? As you can see here again, 60% of people living with HIV around the world were living in sub-Saharan Africa, 22 million. If you contrast that with the number of people living with HIV in North America, Western and Central Europe, it was only 2.3 million. It's an amazing difference, tenfold the number of people living with HIV in some of the poorest countries in the world. Another way of looking at this disparity is to look at the map, this map of the world, and just focus on Africa. This is just a geographic map of the world. You might say that there are lots of people with HIV in Africa because there are lots of people who live in Africa, but that's not what the data show. If you actually configure the map based on the proportion of the population in various territories, you can see that actually Africa has less numbers, less proportion of the population than, for example, Asia. And if you lay over the map of the distribution of HIV cases, you can see the dramatic impact of HIV on sub-Saharan Africa. In this map, if you look alone, this large swath of Africa is South Africa. a country with 40 million people that has the highest numbers of people living with HIV, 5 million in total. Not only was there an impact in terms of people living with HIV, but there was a remarkable impact on life expectancy. Life expectancy is the average duration of life from birth. What's amazing is that since 1950, several African countries had had a dramatic increase in life expectancy, starting in 1950 for around 45 years of life expectancy to almost 60 years by the 80s, 90s. Then you can see what happened with the advent of the HIV epidemic and the plummeting of life expectancy in these countries, almost the loss of all the gains that had happened over these many decades. A horrible tragedy for many of these countries and these societies. If you contrast that with what's happening in life expectancy in other African countries that have very low HIV rates, you can see that these countries are doing quite well. They continue on a wonderful trajectory. So HIV had a dramatic impact on life expectancy in many of the severely affected countries. But not only did HIV have an impact on life and death, but it caused a huge amount of suffering, demonstrated here in some of these photographs of children, women, men, who suffered without access to any treatment at all for years and years and years until they succumbed to their illness. Indeed, when one thinks about it, we already had the treatment. We knew what we can do, but we could not bring it to the people who really needed it, to the millions and millions who needed treatment. So when I think back about the theme of the International Conference in Vancouver, it certainly was one hope, but it was not one world. However, the voice of Africa was heard at another International AIDS Conference in 2000 in Durban, South Africa. At that meeting, Africans, people living with HIV in Africa, their advocates and people who cared for them, as well as many, many other people from around the world, were clamoring, asking for treatment to save their lives and to save their communities. However, there were many skeptics. These skeptics had many, many different reasons why they thought it was not wise to bring treatment to Africa. They feared that patients just won't take the treatment due to stigma. They won't come. They said that patients can't take the medicines regularly. They just won't be able to do it. They said that you run out of medications, what's called stock out of medications. They said that not being able to take medicines and running out of medications would cause the spread of resistant, very resistant severe viruses that would spread like wildfire around the world. They claimed that HIV treatment was very complicated. There were very few doctors and nurses with limited skills that just wouldn't be able to do it. And lastly, they claimed there was no appropriate clinics, no equipped laboratories. These were all questions, legitimate questions, that we felt compelled that we had to answer in order to convince the skeptics and to bring access to treatment. Indeed, what people called us and other people who were trying to push for bringing access to treatment to the poorest parts of the world was that we were misguided. They said, just focus on prevention and forget about treatment. Forget about this generation of people with HIV. It's just a lost generation. Just focus on the next generation. Don't even try to bring treatment. However, that was impossible. This disparity was so unjust, and knowing that we had at our fingertips something that could save lives was just completely untenable. And it was at that time that the MTCT Plus initiative was established with the support of the late Dean Alan Rosenfield and support from 8 large foundations in this country who generously supported this program. What we tried to do with MTCT Plus is to have a proof of concept, to demonstrate that something can be done, to prove that the skeptics were wrong. So the idea was you took women with HIV who were pregnant. We knew that if they took one pill during labor and their babies took one dose of medicine, that you could prevent the transmission of the virus from the mother to the baby. But that limited approach didn't help the mother. It didn't treat the mother's disease. So what we tried to do is to show that it was very important to prevent the transmission to the baby, but it's equally important to save the lives of the mothers and the fathers and others in their family. So the MTCT program was very similar to the approach we took in Harlem. It was founded on the principles that I described to you, the family-focused approach and the mosaic of services. The idea was to enroll pregnant women in MTCT Plus and give them a mosaic of all the services they need to take care of their HIV infection, from clinical services to psychosocial support to prevention services, family planning, nutrition, everything they needed. But at the same time, to also provide the woman herself could invite other infected individuals from her family to also be enrolled in the program. A truly holistic, family-focused approach. There were 13 programs that were developed around the world to try to demonstrate that this could be done. Many of them in sub-Saharan Africa and one program in Thailand. Indeed, the scholarly work from the MTCT Plus initiative, demonstrated by many of these papers and many others, showed that yes, it could be done. It demonstrated that this could be done in this manner. Indeed, proving the skeptic is wrong can be demonstrated by just one figure that I will show you here. There's one measure of how a person with HIV is responding to treatment is what's called the CD4 cell. The CD4 cell is the maestro of the immune system, the most important cell that protects people from infections and cancers. And as you can see here, that these numbers of CD4 cells were quite low amongst the individuals that were enrolled in MTCT Plus. But look at what happened as they were on treatment. The increase in these cells and the response was quite similar to what you'd see in the developed country, what you'd see in New York. So here was a proof of concept that it could be done. However, this MTCT Plus was able to enroll thousands of patients, men, women, and children, but there were millions out there who needed treatment and needed it urgently. And they were now clamoring for treatment. In 2002, two key programs were established that really turned the whole approach around. One was the establishment of the Global Fund to fight AIDS, tuberculosis, and malaria, and the establishment of PEPFAR, the President's Emergency Plan for AIDS Relief, a US government program. And as you can see here from the graph of the funding for global AIDS, you can see how low the funding was in all these years while the epidemic was growing in Africa and around the world. And then with the establishment of the Global Fund and PEPFAR, the exponential rise in the amount of funding available to combat this disease and tuberculosis and malaria. So it was through PEPFAR, the US government program, that we received funding to take the proof of concept to scale, to see that can we go beyond thousands, can we go to tens of thousands, can we go to hundreds of thousands, can we go to millions of people who get access to these treatments. So as we embarked on supporting the implementation of these programs, we determined what are the principles that we'd follow, would guide us through our work. So our mission at ICAP is centered around what we call the sacred triad. That triad is of research, service, and education. A sacred triad. Our research addresses the fundamental questions of how we can serve and improve the quality of life. Our service is about taking the research findings to scale. And education, through education, we strive to instill the knowledge and the skills in both research and in service. There was another principle that guided our work from the very beginning, and that was the principle of partnerships. We believe that we must work with partners on the ground, that these partners would include ministries of health, academic institutions, community-based organizations, research centers, but always working with a partner hand in hand. This meant that day in, day out, this meant that we listened as well as we talked, and we supported as well as we did, and we also guided at the same time as leading. So this is where ICAP works today and has worked for several years. ICAP currently works in 20 countries around the world, the United States, many countries in sub-Saharan Africa, and you can see in the light blue, and also several countries in Central Asia. In order to go to scale, one had to think about how to do it. And the one way to do it is to try to think about the health system itself. and try to address the fundamental problems with the health systems. The paucity of healthcare workers, as noted here with the overcrowded clinics, the overcrowded hospitals with people sleeping on the beds and on the floor, the dilapidated facilities, the inadequate pharmacies and laboratories. So our focus was on supporting infrastructure, taking a clinic that looked like this and creating a clinic that could actually provide care for people with dignity. Taking a laboratory that looked like this and creating a laboratory that looked like this with people who are knowledgeable and able to do the services quite competently and effectively. It also meant that we needed to develop systems for training and mentorship. And by mentorship, we meant that we'd be right there sitting next to the people as they were learning so they acquire their skill and maintain those skills. It meant that we had to support what's called task shifting, meaning in settings where you have very few doctors, you had to be able to shift the tasks to other types of healthcare workers, to nurses or outreach workers or peer educators. It meant that we had to support and train the peer educators, people living with HIV themselves, who have become an important part of the health systems, providing support to others, but also going beyond the walls of clinics to outreach in the community. It also meant that we enabled the same system we had here of multidisciplinary teams providing care and support and counseling. And this served as a wonderful opportunity for our students. And there have been tens and tens of students from Columbia and elsewhere, from across all the schools of Columbia, who've had the opportunity to go and do and be involved in this work. We call it ICAP's Next Generation Internship Program. We also knew that we had to provide the multitude of services that I had mentioned before, the mosaic, the same mosaic that we established in Harlem. And it also meant that we had to have a family-focused approach. But here, in addition, in an African setting, we knew that the household members would be very important, supporting the people living with HIV and others in the community. What has been accomplished over the years since the establishment of ICAP's international global programs? 3.5 million people have been HIV tested. HIV testing is very important. It's the gateway to getting access to treatment, and it's the gateway to getting prevention services. Almost 2 million pregnant women have also been tested, a very important first step to enable these women to get access to medications that can prevent mother-to-child transmission and therefore decrease the numbers of children and babies born with HIV. And 1 million people with HIV have received HIV care and treatment. You can see here 1 million in care and about more than 500,000 who are receiving HIV treatment. Actually, when you think about the PEPFAR, all the PEPFAR programming, the contribution by ICAP is about 15% of the total numbers of people who are receiving treatment. So we demonstrated again that skeptics were wrong through scholarly work and demonstrating now that yes, scale-up can be done. Not only can programs be implemented, but they can be scaled up. And we also demonstrated that you can see an important impact on the patients themselves. Now our part was we're only one of many, many players who also contribute to the scale-up of treatment around the world. If you remember, by the end of 2002, there were less than 100,000 people in low and middle income countries with access to HIV treatment. Miraculously, over the last several years, you can see that by the end of 2010, there were 6.5 million people living with HIV in low and middle income countries who had access now to treatment. I believe this is a public health achievement of historic dimensions. Now, what has been the impact? You can start people on treatment, but what has been the impact? It's very palpable when you look at mortality and death. As you can see here in PEPFAR-supported countries with a lot of HIV, with the establishment of PEPFAR, there was a rapid decrease in the numbers of death. Contrast that with death rates in other countries that were not receiving this kind of support. In addition to just the impact on prevention of death, there was a remarkable impact on wellness. And you can see this here in this figure these are workers in tea plantations in Kenya. And you can see over time how of HIV-infected workers, their productivity decreasing over time. And then when they initiate HIV treatment, their productivity increases again. So not only are we saving lives, but fantastically, people can go back to work and can support themselves and support their families and their communities. However, there were new skeptics. And the new skeptics would say, you can't cheat your way out of this epidemic. We knew that as even scale-up of treatment was going on, there are 2.5 million people who get infected with HIV every year. This equates to about 7,000 new infections per day. And of those, 1,000 are children who are infected every day around the world. There have been advances in HIV prevention over the years. I don't have time to go through them, but I couldn't resist showing a hieroglyphic, Egyptian hieroglyphic, demonstrating male circumcision. Because as maybe I don't know if many of you are aware of it, but male circumcision has been found to be quite an effective HIV prevention intervention. So men who get circumcised cut their risk of acquiring HIV by half. But there have been several other studies that have been involved. A study looking at prevention of transmission in couples in Lesotho, and some domestic studies here in the US, the ISIS study looking at HIV amongst women at risk, and the treat link to care study that's also looking at prevention of HIV right here in New York City and in Washington, DC. But probably the most exciting work and advance happened the middle of last year, when the results of a very important study were released that demonstrated that, yes, treatment is prevention. They're actually treating, this was demonstrated in couples, where if you treat in a couple the HIV-infected individual, you can prevent transmission to their HIV-uninfected partner. This was nominated and actually won the Breakthrough of the Year by Science magazine. So the good news is that maybe we can treat our way out of the epidemic, but we have to wait and see. Now, beyond HIV treatment and beyond HIV prevention, what else have we learned? It's very important to realize that the barriers that people have had to overcome to build HIV programs, whether they be access to services, having healthcare workers, having an infrastructure and equipment, having supplies and medications, all of these barriers that we've had to overcome in establishing and supporting HIV programs are the same barriers that others face and all of us face, the global community, if we want to tackle maternal health or child health or tuberculosis or diabetes. They're all the same impediments that we face. So there are many lessons learned from HIV that can actually advance the battle against many of these other health threats. And clearly, the same parts of the world where HIV is quite prominent are the very same where you also have a disproportionate impact. If you look at the map at the top of the impact of maternal mortality in sub-Saharan Africa, disproportionate impact. You look at infant mortality. You look at child mortality. You look at tuberculosis cases or malaria death. It is the same places where HIV has its impact. So there are lessons to be learned from HIV, and it can serve as a platform to try to address many of these health threats. And out of this work, we started demonstrating that, yes, you could think of HIV as a stepping stone to trying to tackle much more than just HIV. But the work is not done. What lies ahead? Even though so much has been achieved, and there are now more than 6.5 million people who are receiving treatment in low and middle income countries, there are 6 million additional people who need treatment today. There are 2.5 million that need prevention, so they don't acquire HIV. And there's a global campaign to try to eliminate HIV in children that has a very ambitious goal of eliminating new HIV infections among children by 2015 and keeping their mothers alive. And there's AIDS in America, often forgotten but not gone, with our own community right here as one of the epicenters, the hotspots of this epidemic. So at this time of great optimism, where we know we have the tools, we have the means, we have the knowledge, we've proven the concepts, we've demonstrated the possibilities, we're facing enormous challenges. Enormous challenges because of time of resource constraints, shifting of priorities, confusion of priorities, It's a fragile moment in the history of the response to the HIV epidemic, but I also believe in the response in global health in general, and the response for public health. So I go back to the title of my talk, Global Tragedy, Lasting Triumphs. 30 years ago, when I first glimpsed that 1991 MMWR publication that described the first 5 cases of AIDS in the US, little did I know then that this was the beginning of a great tragedy, the beginning of the epidemic of our generation. Little did we know then that over 25 million people around the world would lose their lives to HIV. No one would have imagined that this virus, HIV, would reach the furthest corners of the globe and touch almost every community around the world. Yet despite this horrific tragedy, I cannot help but reflect on the epidemic's lasting triumphs. HIV has motivated a remarkable scientific renaissance that catapulted forward the disciplines of virology, immunology, cell biology, and drug discovery, among others. HIV has deepened as never before the relationships between scientists, institutions, practitioners, and simply people around the world, bridging what previously would have been considered insurmountable divides. HIV has motivated communities and healthcare workers to rise and overcome overwhelming challenges and achieve so much using their own ingenuity, diligence, and insights. In doing so, they proved the skeptics wrong. The HIV epidemic has transformed health systems beyond just dealing with what ails someone today at the very moment when they see a nurse or a doctor, to a system that's committed to keeping people well for the long term and treating them with dignity. Ultimately, what I believe is the most remarkable and truly lasting triumph is how the HIV epidemic has transformed people and communities. Now, who would have imagined individuals from the most disenfranchised communities in this country and around the world, and the poorest countries in Africa, standing up and demanding, and I mean demanding, to sit at the table as resources are allocated and as programs are designed? These are the very same people who had for generations silently accepted their lot. Now they were speaking up. They were demanding high-quality services, refusing to be left behind, refusing to be forgotten. I believe these are just a few of the lasting triumphs. Colombia has been my home for close to 25 years. It's hard to imagine. To Colombia, I owe a deep debt of gratitude. It has given me the support, the guidance, the intellectual space to embark on the long journey that I described to you tonight. We have gone into uncharted territories, and Colombia has gone with us. We have faced singular challenges, and Colombia has been there with us. Others with less vision might have balked, but Colombia never has. And we have many more journeys ahead of us. Looking ahead as we move forward with determination and optimism, we are committed to the vision for this university that was set forth so long ago by President Lowe, and the vision that's kept alive today by your vision, President Bollinger. Your vision of a global university that hews to the highest standards of research and scholarship, yet understands that ultimately these achievements will only be enhanced by how we grapple with the great problems of humankind. I am honored to work with some of the most remarkable people in the world. Some of them are here today, tonight, but many are elsewhere around the world. I work with tireless fighters who never give up, endlessly striving for better ways to solve problems, more creative means to answer questions, new approaches to save lives. I have no words that can adequately express my admiration and appreciation for their commitment, their hard work, their creativity, their integrity, their intellect, their generosity, and their continued aspiration to making a difference in the lives of people around the world. On a personal note, HIV has certainly defined my own professional career. But beyond that, HIV has had a much more profound effect on my life. I do wonder sometimes whether HIV has made me a better doctor, one willing to listen better and to care more. It's likely that it has made me a better scientist, one eager to derive questions by listening very carefully to my own patients. It has made me a better team player, relishing working with teams as we tackle complex challenges. Perhaps in the most fundamental way, I believe that HIV has made me a better person, someone more open to the appreciation of the diversity of peoples around the world, a person better able to empathize with the many constraints that people face day in and day out. For that, I will always be enormously grateful. Thank you. Thank you.
Dr. El-Sadr, thank you for that wonderful, illuminating, and human and inspiring lecture. There's time for questions and answers for a few minutes, but I want to make sure everyone is aware that they're invited to a reception in your honor that will immediately follow the question and answer session. And to my boss, whose introduction, no doubt eloquent, that I missed, I will provide an excruciatingly detailed traffic report offline. If you have a question, you might want to step to one of the microphones that are available. Please say your name.
I'm Steve Moore. I wanted to know, Dr. Wafaa, if with the decreasing funding now with the Global Fund and with PEPFAR also going to other issues, do you see any optimistic scenario for the sub-Saharan African countries, particularly taking over some of this burden themselves and scaling up with their domestic financial and human resources?
Thank you. Very important question, interesting question. I think there are a couple of things that have been happening. As many of you are aware, the Global Fund has had difficulties in soliciting funding for the next rounds of its grants, and the PEPFAR funding is plateaued. It hasn't decreased, it has plateaued. So there's been a lot of introspection and discussion about how do more with less. How do we expand? How do we double the people we need to reach without doubling the amount of funding? There's a lot of talk about efficiencies and economies of scale. There's a lot of conversation now, and there's actually the evidence to demonstrate that the cost of providing HIV treatment has decreased substantially over time and is continuing to decrease. So I think with the lessons that have been learned and these early data that show the decrease over time of the cost of some of these programs, I think we can stretch the dollars more and do more. There's also been ongoing from the very beginning, I just want to make it clear, that the countries where we work, they've been very invested in these programs. While a lot of the external funding has helped, but they've also used their own facilities, they've also used their own systems. And there's more and more of a coming to the table by many of the countries to try to see how they can also assist in trying to cover some of the cost of HIV, of taking care of HIV, but also of tuberculosis and malaria and many of these threats. I think realistically, though, these are some of the poorest countries in the world, have very few resources, have very severe epidemics. I think we have to continue to push for more funding. In the US, it's less than 1% of our gross national product that goes to external assistance. It's a tiny drop in the bucket, and I think we can do more. We have to continue to advocate for funding for important programs like this, at the same time trying to learn how to mobilize the resources within the countries, use creative means for them to contribute to the work, as well as at the same time push very hard to decrease the cost of programs, decreasing the cost of drugs, trying to do task shifting to less costly cadres of workers, and many, many other innovations that are ongoing. But I believe it is a moment of crisis. It's a very important defining moment in the global response to public health and in the arena of public health in general.
Yes.
Thank you very much for your work and your talk today. It struck me that I graduated from high school exactly a week before that MMR report, and had seroconverted by 1985. And in all of those early years, we were sort of left to our own devices. And that sort of trajectory of self-help and acupuncture and herbs and focus groups, and finally starting the medicines, and now having been on the meds for so long, brings two questions to mind. The first is, now that it's become a chronic manageable disease, the management is lots of meds for long periods of time, and the overall long-term impacts on aging and long-term treatment are the new problem for AIDS, and are going to become the problem down the road in the African communities. And a lot of the treatments, at least a lot of the herbal treatments and folk remedies they have the sense that they're more part of the culture of self-help in other communities. Has there been any kind of attempts to step in and approach the treatment for the treatment, the amelioration of the side effect profiles?
I think yes, you're right that especially in the early years where there was no effective treatment, there was a lot of use of what we're calling complementary medications or herbs, and they continue to be used. I think fortunately we have, in addition, very effective medicines that can actually save lives now. I think even in many of the poor countries around the world, there's a substantial number of people who utilize traditional healers and traditional medicines. And I do think that there have been some attempts to try to engage such traditional healers and providers in the community of the health system itself, in some places with more success than others. But everywhere where you've looked and you ask patients the question, have you seen a traditional healer? Are you taking traditional medicines? The vast majority will indicate that they have, at least at some point. So I think it's important that we continue to look and to do research to actually see what the effects are of these medicines. Can they ameliorate side effects or can they cause side effects? We don't know the answer.
Thank you very much for an inspiring lecture. I previously worked with the Gavi Alliance, and similar to the Global Fund, they involve civil society and ministries of health from both developed and developing world and the private sector. So my question is, what role do you foresee for the private sector, including pharmaceutical companies, not only in providing greater access to medication, but also in overall health system strengthening?
Yeah, a very good question. I think obviously pharmaceutical companies have been very engaged in this discussion. And I think HIV actually was very important in transforming the whole landscape of medications and access to medications, and particularly with the use of generic medicines. Without the availability of generic medications for HIV, this would not have been possible. It's the generic companies that started out largely in Asia, in India, but now there are many generic companies, generic companies in Africa as well, and they're able to produce these medicines at substantially lower prices. For example, an annual treatment of a patient in the US could be up to $10,000 a year. There are regimens now that can be used in Africa for almost $100 a year. So there's the involvement, the engagement of the pharmaceutical industry has been very important, as well as the whole issue of working around the patents and so on. Involvement of the private sector has been a bit more complex. I think there's a good experience with large companies. There have been several examples of, for example, mining companies in South Africa as a private sector establishing programs for their own workers, but not only for their own workers, but the families of their workers and others in the community. There have been other industries that have really risen to the occasion and sort of tackled HIV and tackled health in general. But I think the more difficult part has been the efforts to engage the private practitioners, individual private practitioners, who remain really not fully engaged in the public health response in many of the countries. And I think that's your point is very important, and we need to think of them as expansion of the health systems. If we can engage the private sector, and particularly private providers, in public health, I think we would really help our cause.
Perhaps we can have just these last two questions. I'll ask you to go first, and then you, and then Dr. El-Sadr to answer them both.
Great. Jamie Eliades, thank you, Wafaa. Question for you. One of the struggles I had when I was working in malaria is, despite the fact that we seem to be making great strides, the concern always was with a program that was set up really very vertically compared to the rest of the healthcare system. And at some point, the lives we were saving from malaria would succumb to some other disease because we had systems that weren't flexible, they weren't adaptable. ICAP seems to be taking this into account, and especially in the area of human resources and sharing of responsibilities. I know this is a very general question, but it is, what recommendations based on the work that you've done would you have to other initiatives, be they TB initiatives, malaria initiatives, that are trying to save lives while integrating into healthcare systems that aren't yet fully developed, sometimes by a long shot?
Thank you, Jamie. I think the...
So we take the other question first, and then you go into the book.
Okay.
Mine was virtually the same question, and thank you. This fills me with pride to think that you're part of our faculty and that I'm part of your faculty. My question was simply, to what degree that map that you put on of the layering of other diseases is indicative of a siloing effect? To what extent is AIDS and the other diseases and the treatment being integrated into an entire public health system? Or to what degree are we just seeing these as individual problems that have to be addressed individually?
Yeah, I think the questions are very similar, so I can address both of them together. I think it's actually, it might be, I think it's often a misconception when people sort of use the broad strokes that HIV programs are vertical. It's an oversimplification of a complex health system. For example, if you have a health clinic, like the health centers that I showed you photographs of, there is no HIV room, there is no HIV lab, there is no HIV pharmacy. It's the whole system that's there. And training that pharmacist, you're training them in how to procure medications, how to think about forecasting and so on. There's a huge spillover effect. So I think particularly at the lower levels of the health systems, there's a tremendous amount of integration that's happening and a tremendous amount of systems strengthening that's happening in those. I think the bigger challenge is, I believe, is you have to stop and think as you're designing the program from the very beginning and say, how can I design a program that will have those effects, those spillover effects? How can I design a program that actually strengthens the whole health system? And that's the question, is I think often people are trying to retrofit, to go back and say, well, how can we make it go back and see what it did, rather than stopping and thinking, we're going to design something that will have those other spillover effects. I mean, for example, in some of the work that ICAP does, we don't solely focus on HIV. That'd be rather silly. I mean, you're also doing screening for tuberculosis at the same time. You're strengthening the labs for TB. You're giving the pregnant women bed nets for mosquitoes, for malaria, giving them prevention medicines for malaria. So I think the more we try to bring the elements that make sense together, I think that, in the end, that will advance public health much further. I do think it's an area that requires a lot of inquiry and scholarly work and research to understand really how do you integrate. We now have a sense of how to scale up. How do you integrate, and what are the models of integration? How do you measure the outcomes, and so on? So I think it's a rich area that requires a lot more work.
Dr. El-Sadr, thank you for a wonderful lecture and an inspiring career at Columbia.
Thank you. Thank you.
You're all invited to the reception.